Alrighty, and welcome back. Again, I'm Jim Flischner, and we're going over the Advanced EMT. We're using the Advanced EMT, a clinical reasoning approach, second edition updated book. And now we're going to move on into chapter 2, which is emergency medical services, healthcare, and public safety. All right, tons of objectives to go over, but I'm not going over all of them, so you can check them out in your book. All right, so the history of how the modern EMS system is important to understand it, and its relationships with medical system, public health, and the public safety. A number of events, individuals, and groups have influenced the development of the EMS system, and current and future direction in EMS are determined by published documents and research. In the beginning, or its infancy, EMS was guided by physicians and nurses. There wasn't EMTs, there wasn't paramedics, the physician and nurses. Often the funeral homes were responsible for transporting. Later on, we'll talk about the history going on, but they were responsible for the transport of the sick and injured to the hospital, and they would transport them by just putting a person on a cot. This is where the term ambulance driver came from. Literally, they would take a modified hearse with a portable stretcher, place the patient on the stretcher, put him in the back, and drive him to the hospital. That's where the term ambulance driver came from. EMS now has matured into a self-regulating occupation. We have governing bodies and groups to govern over top of us. It's the current EMS currently exists at the intersection, right, of public safety, healthcare, with potential contributions to public health. So right there in the middle of that intersect between public safety, the healthcare system, like the hospitals, doctors' offices, allied health, and public health. Nice little diagram here. All right, so how did it all start, right? Modern day EMS can trace its roots back to what we call the white pages, or the accidental death and disability, the neglect disease in modern society. This is what recognized the need for trained individuals, right? And this is where this is the starting point for modern EMS. Often we get a lot of our stuff from military, especially our trauma stuff. We'll talk about that more in depth here in a minute. And we're constantly researching and growing and being advocates for our patients. All right. So, how did we initially transport the sick and injured? Let's go back a little bit. Here it says in 1860s they were horse-drawn ambulances, but the first documented use of EMS or transporting patients was actually in the 1790s during the Napoleonic Wars. One of their surgeons found that if we transported the injured patients off the battlefield back to the surgical area, they had a better outcome and less mortality rate if they did that. So that was the first documented. Now here in the United States, our first documented ambulances were horse-drawn, used in the 1860s. There was a couple hospital-based ones that were doing it. And then later on, we went into the hearse as ambulances all the way up until like the 60s or 70s. And then we got more modern ambulances. First Volunteer Rescue Squad began in East Coast in the 1920s, rapidly developed of EMS after publication of the White Pages. This is what a modern day ambulance looks like. We'll talk about all them later on. The first national standard curriculum for EMTs was in 1971. Modern ambulance was developed to carry equipment and allow space for the patient. That's what a modern ambulance was doing. Military influence. Like I said earlier, a lot of our trauma stuff comes from the military. They're kind of the guinea pigs and what works and stuff. Helicopters started in the Korean War and the Vietnam War in the 60s and 70s, and eventually carried over to civilian air medical that we have today. And one of the biggest contributions in the military is the use of tourniquets. I don't know how long you've been in EMS, but even when I was in EMT class, they recommended tourniquet as last resort. Now we're using it pretty quick into our bleeding process. So the tourniquets, hemostatic agents, all that stuff come from the military. There's a nice picture of a modern helicopter tourniquet. All right, so we're going to talk about some key events in the EMS system to help it evolve. Right. So in the 1960s, the AHA began teaching CPR. 1970, the Highway Safety Act was established. Well, it established the NHTSA, or the National Highway Traffic Safety Administration, part of the Department of Transportation, to lead the development of a highway safety program, including the EMS system. So this is where the EMS systems come from. That in the 1970, the National Registry of EMT was established. So the NREMT began in 1970. The Emergency Medical Service Act of 73. This developed federal funding for EMS systems. But in 1981, which we'll go next slide, 1981, the Omnibus Budget Regulation Act of 81 called for consolidation of healthcare funding into block grants administered at state level. So it consolidated the funding for EMS, organized it, and put it at the state levels. The state could hand it out. Say in 1984, we got the EMSC, which is the EMS for children. This was pre-hospital care for pediatric patients. 88, the EMS Technical Assistant Program started. Moving on in the 1990, the Trauma Care System and Development Act focused on trauma systems. This is where our trauma system rankings came from, like a level 1 trauma, level 2, level 3. This came from this act. And it describes what you have to have in this facility to be a level 1, level 2, 3, and so on. 93, the National EMT Practice and Education Blueprint. And 96 was a big year. This was our first EMS agenda for the future. Of course, it was revamped in 2019. The Institute of Medicine, the IOM, EMS at the Crossroads. That's a pretty important document. The National Scope of Practice model came out in 2007. This gave a national scope of practice on all levels, right? EMS education standards came out in 2009. EMS organization implemented MIH programs, which is Mobile Integrated Healthcare, in 2010. And then in 2019, Planning for the Future EMS 2050, which was the education agenda for the future revamped, right? Which gave us what they think how EMS is going to go and with technology and all the other sorts. Now we got to look at some documents in EMS, key documents. The NCS, with National Standard Curricula, EMS Services at the Crossroad, the Agenda for the Future, Education Agenda for the Future Assistive Approach, the Core Content, Scope of Practice Model, and Education Standards. These are all documents that you can research on your own, and I do recommend that you kind of look into them and kind of look at them. So to develop the EMS system, it took thousands and thousands of people, and it's constantly taking more people. But we want to focus on a few key people in EMS, pioneers, so to speak. So we're going to talk about Nancy Caroline. She's an MD. She saw the need for the life-saving emergency care outside the hospital. So she saw the need for EMTs, paramedics. We have to get people trained. So she was one of the first pioneers in this. Dr. Jeff Clausen, he established the protocols for dispatch, which later ended up being the EMD, or the Emergency Medical Dispatchers. So he wrote the guidelines for that in 1978. R. Adam Coley, he's also a doctor. His biggest credit is the golden hour, or how we treat patients in shock. And of course, the golden hour we're going to talk about a lot in this class. but it's from the onset of the injury to surgery, right? We want that to be within an hour. That's our golden hour. Joseph D. Farrington, he came up vehicle extrication, first aid. Dr. Norman McSwain, he developed the PHTLS, or the pre-hospital trauma life support. And then Rocco Mirando, he was the founding executive director of the NRMT, and he was very instrumental in developing that in AEMT. So without Mr. Mirando, you guys may not be sitting here today. James D. Page, the GEMS, the Journal of Emergency Medical Services, and Dr. Peter Safar. He's the one that came up with our modern day CPR in the 50s with airway breathing circulation. He's credited for that. All right, let's move into the components of the EMS system, right? So components serve as a checklist to evaluate the state EMS system. That's what they're there for. And there are 10 components, and let's go through them. Regulation policy. This stated that we had to have each state had to have a lead EMS organization. Most of them were the public health department or the public health departments. Like in Illinois, it's IDPH, or the Illinois Department of Public Health. They're the ones that set the standards for EMS in that state. Resource management. There has to be funding for EMS. So the state has to make sure there's funding for the EMS. Human resources and training. This is what developed the EMT as the minimum staffing on an ambulance. Now, with that being said, if you get into smaller communities and you have populations of less than so many thousand, you can use EMRs on ambulances as assistants and drivers. So you can have one EMT, one EMR. But this standardized that we needed 2 EMTs on an ambulance. Transportation. This guarantees every patient gets a safe and timely transportation to care they need, as far as the facility they need. If we're going to the hospital, if we're taking the doctor's office, we're taking them home, this guarantees them a timely and safe trip. Facilities. We need facilities that are appropriate hospital facilities. Understand that most of our little hospitals in the area are critical access hospitals. They can't offer a whole lot of service, but they can stabilize a critical patient or a very sick patient and arrange transport to a higher level of care. There has to be a communication system, not only for the patient to be able to communicate on an organized number, which is 911, but there also has to be communication between dispatch, EMS, EMS to EMS, EMS to other public safety officials like fire and police officers. Public information education. We have to have medical direction. So each region has a medical director. We'll talk about it a little more, what the medical director later on. Trauma systems. You have to have a trauma system in your state. You have to know, and each trauma system is designated. Each hospital is designated at a level of certain trauma. I know most of ours in our area are like at level 3 or even 4. But we do have several level 1 traumas in the state of Illinois. And there has to be a way to evaluate or CQI, right? You have to be able to see what we're doing right, see what we're doing wrong, how we fix what we're doing wrong. Components of EMS. State legislation registration addresses standards in EMS education, right? They regulate the licensures, education requirements, provision of EMS services, the scope of practice of an EMS provider, communication medical director, and other aspects of EMS. So they're in charge of all this stuff, right? So the state legislation, which and then is governed by the IDPH. Um, the EMS agenda for the future, goals of education, core content. These are all good. We can look at. We went over a lot of these. Uh, so EMS system configuration. Some are fire-based systems, which means you're a dual service, like a fire department that has both fire and EMS. We have a few of them in our area. There's hospital-based systems, which means the hospital owns the ambulance service and runs it. We have a couple of them as well in the area. Private service contracted by local governments. So this is like your private ambulance service is like, let's say Abbott, because everybody knows AMR. Sorry, not Abbott, AMR, and then a county will contract them in to run that or cover that county for them. That's what this means. Municipality third services. That's your volunteer or your volunteer like fire departments and stuff like that. And there could be have a combination of all of these, right? The staffing configuration may vary. You may have two paramedics on an ambulance. You may have a paramedic advanced on an ambulance. You may have, and in my area, it's more common to see one EMT, one paramedic, or you can have a BLS unit that's got two EMTs on it. And if you get into the volunteer world in the small communities, you may have one EMT, one EMR. Um, current workforce. I'm sorry. Current workforce issues may include safety pay, improvements in reciprocity, and the need to act with more women. Right. Medical direction. Your physician's medical director. This is the doctor in charge of your region. Right. He's in charge of making protocol, overseeing, oversight, making sure everything's going right. And there are several types of medical direction. You can have perspective, which is offline or indirect. That's your protocols or standing orders. You can have concurrent medical direction. That's online or direct. That's when you get on the phone, radio, and actually contact medical control. Or retrospective is a continuous quality improvement. Right. This is how they look at run reports to see what we're doing right, what we're doing wrong. Speaking of that, continuous quality improvement plans. It it sets what benchmarks we're going to measure. Like, are we measuring response times? Are we measuring scene times, transport times, protocol compliance, patient satisfaction? It also is going to tell us how we're going to measure these, right? This is good. This is bad. That's what that's going to do. That's the acceptable levels. What are we going to do if something's not up to par? That we're going to address this. And we're going to need to reassess interventions to improve. If we got issues, we need to fix it, right? That's what that means. All right. Going into the future, one of our greatest challenge is developing new leaders who continue to move forward. Anyone who has passionate knowledge can be a leader, can make a difference. You don't have to be EMS manager to be a leader. EMS involved from the need to reduce preventable traffic deaths and manage out of hospital cardiac arrest. That's where we come from. All right, let's go over the summary here real quick. Today, EMS is a compact system of private and public agencies to provide a coordinated delivery of emergency medical care. The system is integrated with public safety, health, and public health. EMS is guided nationally by the NHTSA, or National Highway Traffic Safety Act, or agency. But each state has laws and regulations that structure the EMS. So each state, not only the state, you'll have regions in the state, and they all have their own laws and regulations. EMS professionals work under the guidance of the physician medical director. EMS provides transports to patient healthcare facilities for emergency ongoing specialty care. Uh, Evaluation programs are used for CQI, right? How to constantly improve our field. That's why we use them. Contributions of many individuals allowed EMS to make great strides since the 66. So remember, 66 is an important date because the white pages or the accidental death paper came out in 1966. So from then, we've just been constantly growing. EMS agenda future set current direction of the profession. All righty, that'll do it. I will see you on chapter 3.